The stage is yours.
Thank you very much, Dr. Junaid, and thank you to the Scientific Organising Committee for the opportunity to participate in this webinar. Particularly Dr. Monica, Dr. Rajesh, Dr. Sridhar are all good friends of mine, and I always enjoy going to Dubai in person. So I'm a bit disappointed that I can't be doing that this time, but at least we can discuss over the traditional Zoom video conferencing now, and we can share some knowledge. I'm looking forward to talking a little bit about some of my ideas about the PDA currently, and hopefully to have some questions at the end about your thoughts about current perspectives of PDA management in the UAE. My slides are okay? We can see them? Good. So
yes, your slides are okay.
Great, thank you. So some of the topics that I would like to cover over the next 40 to 45 minutes: patient selection and targeting, an important aspect as we move forward with management of the PDA. What do we use? Volume of shunt, the importance of the timing of treatment, what are some of the risk groups that we might be targeting. A little bit about efficacy and drug dosing and the importance of that in our decision making around PDA treatment. Talk a little bit about this rise of therapeutic nilhism, the feeling that we shouldn't be doing anything about the PDA and we should allow it to spontaneously close. And is that safe? What are the implications of conservative management? And the inevitable increase in babies discharged home from our unit with an open PDA because of reduced treatment early on. Some new management approaches, medications, the device closure that's rapidly becoming a reality for very small babies in the NICU. And then finally talk a little bit about personalised medicine or prescriptive medicine and where we might arteriosus. Often the big meta-analysis by Bill Benitez is the thing that comes to mind when we're looking at outcomes for ductal treatment. That was a large meta-analysis of almost 50 randomised controlled trials, 5,000 babies. And if we look, sorry, my slides aren't moving, so let's see what happens here. So if we look at the outcomes for this meta-analysis, arranged as any treatment for PDA, prophylactic treatment for PDA, or all treatments, both prophylactic and clinical, you can see that we achieved the aim, or the aim of reducing ductal patency was achieved in all cases, but there was no, and apart from intraventricular hemorrhage greater than grade 2, which you can see doesn't cross the line of unity, pretty much every other outcome that was assessed in this trial, be it BPD, death, SIP, NEC, PVL, and neurodevelopmental outcomes, there was no discernible difference between babies who had received or been in the active treatment arm, babies who had been in the placebo arm, even though we managed to close the duct. And so this has driven a lot of the concerns about the effect of treatment on babies and whether there are any actual benefits to treating the PDA. And so the primary outcome of ductal closure was achieved, but there were no medium to long-term benefits except for IVH prevention. So we have persisting uncertainty. Are we doing something wrong here? And if we look more carefully at that meta-analysis, and many meta-analyses in the areas that we are involved in as neonatologists, we find that there's a lumping together of a large number of different types of patients. So there's poor patient selection, particularly from the gestational age, postnatal age point of view. Many of the babies in these trials were 30 to 34 weeks gestation, a gestation that we wouldn't usually treat at all in current NICU management plans. And the other problem is many of the trials were in NICU as they were 20 years ago. So the value of analysing those trials in the current setting to help us make decisions is questioned. There were problems with definitions. What was a hemodynamically significant PDA? Many of the early trials just documented it as an audible murmur. for example. So that is quite different to what we might do today to assess the significance of a PDA. And there was no or minimal documentation of the underlying physiology. And as a result of that lack of understanding of the mechanisms of harm and when the right intervention point should be, we're homogenising a heterogeneous group, and that causes problems with subgroups who might be responsive, who are not being treated because they are being overwhelmed by babies who didn't really need treatment, for example. And add to that, we have the high rates of open label treatment. In many of these trials, more than 50% of babies actually received active treatment at a later point in their nursery stay. So to answer some of these critics of the large meta-analysis, Professor Benitez and colleagues went back just a couple of years ago and looked at a more specific way of meta-analysing this group. And they looked at babies, treatment in babies who received, open label treatment less than 50%, babies who were born less than 29 weeks, and in the more modern era, since 1990, and babies aged at treatment less than 5 days. So they were trying to answer some of these criticisms, but unfortunately, again, what they found is the same thing, that ductal patency was achieved in all of these subgroups. But then if you look down the unity line here for the odds ratio, again, no real any other differences in outcomes apart from that same outcome of IVH greater than grade 2 protection. So even looking at these subgroups, we didn't get much positive result from closing the PDA in the meta-analysis setting. So my suggestion when we're talking about meta-analysis is, instead of this title, Treatment of Persistent PDA, Time to Accept the Null Hypothesis, maybe we should look at it this way, that meta-analysis of the PDA is problematic because we are lumping all of these babies with different physiologies and different requirements for treatment into the same group, and then trying to get a result from that. The reviewers, when Bill Benitez summed up his last meta-analysis, the review conclusions were, in the absence of evidence, decisions about treatment of PDA should be guided by clinical judgment, informed by experience with conservative management strategies, as well as considering the pathophysiology, which I think is a very important observation. And they need to be balanced, these things need to be balanced against potential adverse effects. So that brings us to this decision-making process that we do every day as neonatologists for many areas, but particularly in the area of the PDA. So the treatment decision is a balance between the treatment risks and the treatment benefits, and these will differ in individual patients. The risks that we perceive, the benefits that we perceive will differ. On the risk side, we might be considering things such as the side effects of non-steroidal anti-inflammatories, the complications of PDA ligation surgery, which are real and concerning, the lack of benefit of treatment, as illustrated in those meta-analyses, including the lack of effect on long-term neurodevelopment. And then in behind here is the concern that there is a significant spontaneous closure rate, particularly in older babies. Should we be exposing them to risk when the duct may well close anyway? On the other side of the balance, we have the treatment benefits, preventing respiratory or cardiac decompensation, avoiding mortality, IVH, pulmonary hemorrhage, hypotension. And these are things where there are short-term benefits of early treatment, as shown on that meta-analysis, particularly for intraventricular hemorrhage, can be reduced by prophylactic indomethacin. We've also shown in our trials that pulmonary hemorrhage can be reduced by early treatment of babies with large PDAs. And on the other side of the coin is the concern that treatment might result also in chronic lung disease, particularly with use of ibuprofen. So that's the balance, and it's made even more difficult these days, I find in our nurseries, because we're dealing with less intensive babies. They're often on CPAP or humidified high-flow nasal cannulae, no invasive arterial lines, so we're not measuring their blood pressure, no inotropes, They're often being fed early, which may complicate the giving of some of the non-steroidal medications. So the decision is a little bit harder in the modern era of NICU because we have less sick babies. Therefore, we're less likely to accept risk in our relatively well babies. So how to select babies in our current era is a problem. There are some things that are happening. So paracetamol and acetaminophen was mentioned by Dr. Junaid already as one of the newer treatments available for PDA. And the risks, the side effect profile of this drug seems to be less than the non-steroidals. And we're getting better at selecting babies and deciding about the timing for both medical treatment and surgical ligation. And we have less invasive options becoming available, including catheter device-based closures. All of these things may reduce the risks and therefore make us more likely to treat to get the benefits. And the benefits are also being affected by better patient selection and treatment effect, and in particular, starting to understand the pharmacokinetics of the drugs we use a little better. It doesn't make sense to use exactly the same dose per kilo dose, but the same dose for all types of babies. More immature babies, more mature babies, maybe they should have a different dosing regime, and more work needs to be done in this area. So that brings me to the concept of therapeutic nihilism, which is something that I feel is happening in the area of the PDA. So therapeutic nihilism is the contention that it's impossible to cure people of their ills through treatment, and it's connected to the concept that many of the cures, read treatments for PDA, do more harm than good. And therefore one should encourage the body to heal itself, or in our case, the PDA to spontaneously close. And this will be a familiar argument to those of you who talk to or use yourself the conservative therapy or supportive treatment of the PDA. But we also need to be aware, and this is in our modern Hippocratic oath, that we swear that the benefit of this, for the benefit of the sick, I will apply for the benefit of the sick all measures which are required, avoiding those twin traps of over-treatment and therapeutic nihilism. So on either end of the coin, the best approach is going to be somewhere in the middle. We don't want to over-treat and we don't want to under-treat our babies. So if we look, there's a cycle really here, and you can see where you yourselves fit on this PDA management cycle, starting off with treating all, which was commonplace in some units some time ago. Broad selection criteria based on gestational age or postnatal age or being on a ventilator. More targeted selection, which is where we use more specific things, be it biomarkers or more advanced cardiac ultrasound measures to be more selective in our patient treatment. And that's where I find myself, and where we've spent a lot of time, is targeting treatment. And then we've got this drift into therapeutic nihilism where we don't treat any babies and we await spontaneous closure. And there's a lot of people who've moved to this, a lot of units have moved to this area. And then my prediction for the future is that gradually we'll become more confident in being able to identify babies who will benefit from specific treatments at specific times. And our treatment approach to babies will become more personalised or prescriptive along the lines of personalised medicine. So what about the concept of reduction in treatment and the movement towards therapeutic nihilism? And do we have any evidence for this? Well, this is some data from the United States Pediatrics database looking at over 61,000 infants less than 30 weeks, comparing two time-based cohorts, one from 2006 to 2010 and a second 2011 to 2015. And they looked at the treatment of PDA both medically and surgically. And this is the graph of indomethacin or ibuprofen exposure in babies less than 30 weeks. The closed circle is the older historical cohort, and the open circle is the newer cohort. And you can see that these are the individual units along here, that the majority of units decreased their usage of ibuprofen or indomethacin. Some of them decreased it by quite a lot, from 55% down to 20%. The average was 32% in the older era, down to 18% in the more modern era. So there's almost halving of the exposure to ibuprofen or indomethacin. So there was some movement towards no treatment there. Similarly with PDA ligation, same figure, percentage of infants ligated, the different sites, and the reduction from the older cohort in the closed circles to the newer cohort in the open circles. So on average, a reduction from 8.4% of babies less than 30 weeks being ligated down to about 3%, so almost a third reduction. So there is some evidence of a drift towards decreased treatment there. And this is some interesting data, again, from an American cohort of almost 6,000 very low birth weight infants with a PDA. And you can see that they were tracing not only the reduction in treatment, and so you can see from 2005 to 2014, a reduction in the non-steroidal or COX inhibitor treatment, but at the same time, a rise in other things. So BPD gradually crept up, mortality came down, then started to creep up a little bit as the treatment rates for PDA decreased. So the question is there some unanticipated consequences of our withdrawal, our decrease in treatment rates, both medically and surgically? And this is one of the dangers we have by adopting a different treatment pathway from what we've done in the past, is that there may be unanticipated consequences if we don't do research to understand the consequences more rigorously. So to summarise to date, trends in PDA management, NICU management is less interventional. There is the changing risk-benefit ratio because our babies are less sick for the treatment of PDA. Despite this, there's less medical surgical treatment occurring, and therefore, as a result of that, there are increasing number of infants with an open PDA, both in our nursery and also at time of discharge. So we have some options to adopt the mainly untested conservative management or supportive care alone. We can be more selective and try and identify patients who will get benefit greater than risk from treatment. We can reconsider the effects and indications for surgical ligation and the timing of when we might intervene with that. And we can develop new, less invasive approaches such as catheter-based closure devices. So turning a little bit to some thoughts about efficacy now, and this is just an example about when we think about efficacy, where is it coming from in our cohorts? So this is some data from a summary of some of the Indomethacin prophylaxis trials. You'll immediately see, as is the problem with many of our, well, not problem, but a lot of our data is based on older trials from, as you can see, many of them before 1990. And the TIP trial, the most modern trial here, 2001. This was early treatment trial, so less than 24 hours, intravenous indomethacin versus placebo, and these are the closure rates in the trials. And the active closure rate varied from 73% to 96% in the active arm, but in the placebo arm, the closure rates were also between 20% and 85%. So significant closures occur in the placebo arm of these early treatment trials. So in fact, when you look at this, much of our efficacy that we saw in early treatment trials may be due in fact to spontaneous closure, particularly when we do trials in more mature infants. So babies, for example, who are more than 30 weeks, they have a very high level of spontaneous closure. And if we give them a non-steroidal treatment at the time that they're spontaneously closing their ducts, we may ascribe efficacy to the drug when it's actually the spontaneous closure which is occurring. And what we're finding in our units, and I think others are finding this as well, is as we extend our treatment, PDA treatment, into the more immature infants who have lower spontaneous closure rates, the perception is that the efficacy decreases. But really, I think what's happening is we're losing the effect of spontaneous closure rates, which used to be thought of as an effect from the drug rather than effect of the baby's spontaneous closure. So the efficacy rate of our drugs is actually quite low potentially. To go a little bit further and look at some of the problems we have with trials in the area of the PDA, we have these three problems. We have poor efficacy, we have spontaneous closure occurring, and we have the added problem of open label treatment. So many babies who are randomized to a placebo arm in some of the older trials were able to have open label non-steroidal after the trial period had finished. And so they actually had a treatment which may close their duct outside of the trial. So what does this look like? If we go down the active arm here, we have spontaneous closure, which would occur presumably at a similar rate in both arms. We have the effect of active treatment closure in the active arm. And in the placebo arm, we have the opportunity in many trials to have open label treatment closure even after the period of the trial period has been undertaken. And then we have babies in the placebo arm who don't spontaneously close and presumably don't receive open label treatment. And we have a group of babies in the active arm who, despite active treatment, will have still be open, so they'll have failed treatment. And then finally, there's a group of babies in the active treatment who may actually suffer harm if they don't have a significant PDA. So if you see here that we have a problem in that there's not a lot of difference between these two arms, placebo arm and active arm. And importantly, we often use the placebo arm as a surrogate for the open PDA. So this assumption is if the baby gets placebo, then they'll suffer the effects of an open PDA. And similarly, if the baby has active treatment, then the duct will be closed and they will be protected from the effects of an open PDA. But as you can see here, this is too simplistic, and it's not what happens in the typical arms of a PDA trial because of these three problems up here, which muddy the waters significantly. So that is one of the reasons why we don't see, I think, significant differences in important outcomes because of this mixing between the two groups, because of these characteristics when we're looking at PDA management. So what can we do to help in our selection? So we want to be able to select candidates for treatment who have a good response rate, who are going to have benefit from treatment, and who will have a decrease in harm. That's our ideal selection, what we would like to achieve by selecting babies. And we can select babies in different ways. We can use clinical criteria, lower birth weight and lower gestational age, more likely to not have spontaneous closure and therefore benefit from treatment. That also is babies who have, mothers didn't have full antenatal corticosteroid cover. Babies who are mechanically ventilated with worse respiratory distress syndrome, increased respiratory support may benefit more from PDA treatment. And babies who are less than 2 weeks of age are more likely to have PDA closure with treatment. And I'll show you some data on that shortly. And then, of course, we have ultrasound, and that's where I've spent a lot of my time, is trying to understand the parameters on ultrasound that might predict the candidates who will have the best response, get the best benefit for the least harm. And you can see there's a series of parameters that we've used, and if we go through that in a graphical way, one of the things that's probably most important is the able to understand the shunt, the systemic to pulmonary shunt, and what is the volume of that shunt. That's probably the key factor that we're interested in, but it's difficult to directly measure the volume of shunt. So we're stuck with some intermediate parameters, and they include things like the diameter of the ductus arteriosus itself. And clearly, the bigger the pipe, the more that can flow down. So the diameter has some relationship to the volume of shunt. We also can look at the flow patterns in the ductus arteriosus, which have some predictive value for significant PDA. Then we can look for evidence of systemic hypoperfusion, whether it be effects on cerebral blood flow with ductal steal, whether it be effects on the gut and lower body blood flow with reverse flow in the and diastole in the descending aorta, or it may be evidence of babies with low blood pressure, so hypotension. So this is the group of babies with a hemodynamically significant PDA have a lower blood pressure than babies without a hemodynamically significant PDA. Then we can look on this side, pulmonary flooding. As the systemic to pulmonary shunt increases, we can have increased pulmonary blood flow, and this may manifest as pulmonary hemorrhage. And in our study and in other studies, increased ductal diameter is associated strongly with increased pulmonary hemorrhage. So that's showing, again, evidence of increased pulmonary blood flow. And finally, at a later stage, dilatation of the heart with the LA aortic ratio and left ventricular end diastolic diameter increasing. And these are the babies who often end up with a ligation. So trying to understand the volume of the shunt using various parameters, often multiple parameters, is one way of selecting patients. So what about a little bit about timing now and the PDA physiology. And along the top here, we have a timeline of a baby's course in the nursery from delivery, resuscitation, the transitional period through day 1. And then if we look at what's happening to the pulmonary pressures, in a term baby, often the pulmonary pressure is quickly drops and it's down to the normal level within the first 24 hours. In preterm infants, that pulmonary pressure drop may be less, and that actually protects, or maybe slower, that actually protects a baby from developing significant systemic to pulmonary shunt. And so initially the left to right PDA shunt is not so large, but as time goes on and the pulmonary pressures begin to drop, there's opportunity for the left to right PDA shunt to increase. And it depends a little on how quickly this pulmonary pressure drops as to how quickly this shunt will develop. And as the shunt develops over time, some babies, there will be increasing left to right PDA shunt because the PDA fails to constrict and close in these first few days. And that again provides the opportunity for systemic to pulmonary shunt. And that can result in some of the side effects some of the effects we see early on, which we may ascribe to the open PDA and the left to right shunt: hypotension, pulmonary hemorrhage, and intraventricular hemorrhage. And then later on, we have the effect on the lungs, and this again is a multifactorial effect rather than necessarily a direct effect from a patent PDA. So if we look at treatment points, if we give baby prophylactic treatment here before any of these things occur, then there's the potential to reduce the incidence of hypotension, pulmonary hemorrhage, and IVH. And as you saw from the meta-analysis, we have evidence for this in terms of IVH, and several smaller clinical studies have shown reduction in pulmonary hemorrhage with treatment at this time point, as well as decreased hypotension. If we treat a little bit later, at the end of day 1, we might start to miss the opportunity to intervene in some of these adverse effects. And as we go along with later and later treatment, there's less and less opportunity to affect these outcomes. And babies in later treatment trials may suffer complications from left to right shunt if we treat a little bit later. So the timing of treatment and understanding the change in physiology occurring and the relationship of some of these outcomes to that is important when we're looking again at the risk-benefit ratio about whether we should be treating an individual infant. If we look at this in another way, along the side here, we have the different approaches to treatment, from prophylaxis in the first 12 hours all the way up to very late treatment for babies developing heart failure at months of age, or no treatment. Along the top here are the outcomes that we might desire: closure of PDA, decreased hemorrhages, decreased ligation rates, and then looking at unnecessary treatment and the risk of NEC and mortality. So in a prophylactic approach, we can obtain good closure of the PDA, we can protect against IVH and pulmonary hemorrhage, we can reduce ligation rates. But the problem with prophylaxis is that we're giving it to unselected patients, so we have an unnecessary treatment rate, and that might also result in side effects which were not in a baby who didn't actually need the treatment. You can take our approach, which is an early targeted approach, so actually try and target treatment, so you get all the benefits of early treatment in babies that need the drug, but you hopefully exclude babies who don't need the drug, so you reduce the unnecessary treatment. And then there's other approaches, early pre-symptomatic, early symptomatic, late symptomatic, with a gradual decrease in efficacy as the baby gets older, no protection from the early complications of PDA, potential complications, and less protection from prevention of ligation. But of course, the treatment becomes more and more specific and necessary as time goes on. And then we have the risks of NEC and mortality in babies who receive no treatment. Again, mainly in epidemiological associative studies that we see these effects, but they are there and of concern if we decide not to treat the PDA at all. So what about timing of treatment? And this is some data extracted from the Cochrane review on PDA treatments, looking at non-steroidals at different time points, 1 to 24 hours, 25 to 47 hours, etc., up to greater than 7 days. And if you look down here at the overall closure rates, you can see that the highest closure rates were in babies who received treatment in the first 24 hours. So there's a little bit of a hint here that treatment may be more efficacious if given early on in the first 24 hours. Is there any other evidence for this? Well, this is a trial from a couple of years ago of a reasonable number of babies, 139 ELBW babies who had an echo diagnosis of PDA. Some were treated at less than 24 hours and others were treated at later time points. These were small babies, 26 weeks, 807 grams. It's a retrospective review of response rates. But what you can see is that the babies who received treatment in the first 24 hours had an 85% closure rate, whilst babies who received treatment greater than 72 hours only had a 48% closure rate. So again, in this single-centred trial, there's some evidence that early treatment means a better PDA closure rate. So one could argue that if you want to get good efficacy and you want to get good treatment effects, then earlier treatment is important. But the other side of that is we need to then be able to identify babies who are going to need treatment, that we think will need treatment later, because we don't want to be giving unnecessary treatment to babies who have closing PDAs. So, moving on to the next topic, failed treatment, what next? Do we do further courses of non-steroidals and put the baby at risk of increased side effects? There is some evidence that longer or prolongation of courses may result, for example, in NEC. We can start to look at other drugs with better side effect profiles, such as paracetamol. And we can look at a supportive approach until we are limited by that, be it failure to gain weight or unable to wean from significant respiratory support. And many units are adopting this approach. We can relook at our surgical closure, which has a very good efficacy, but has significant adverse effects. Or we can wait for the onset of the non-invasive device-based closures, which we'll talk about briefly at the end, a new device that can do that. So briefly looking at other treatments, this is the Cochrane review of paracetamol, published just a year ago. 8 studies, almost 1,000 infants. 5 studies looked at paracetamol versus ibuprofen and showed no significant difference in failure. So similar efficacy with paracetamol to ibuprofen, less side effects in the paracetamol group, less gastrointestinal bleeding. 2 studies compared prophylactic paracetamol with a placebo. Paracetamol again had evidence of closing better than the spontaneous closure rates. 2 studies compared paracetamol with indomethacin. Again, no difference in failure to close PDA, so similar efficacy, but the side effect profile was better in the paracetamol group. In this case, it was less creatinine, less high creatinine levels in paracetamol group. So paracetamol certainly has some place in treatment of the PDA, and it seems to be at least as efficacious as ibuprofen in these initial studies, but with better side effect profile. And just to draw your attention to this article that many of you may have seen, but this is, again, a very interesting way to look at some of our data around treatment modalities versus outcomes. This is the network meta-analysis by Suvik Mitra et al., published in JAMA 2018, 68 randomized controlled trials, almost 5,000 infants. And they used a thing that's fairly hard to explain, and you need to go and look at this paper yourself, but the mean surface under the cumulative ranking curve, which was a way of trying to rank the various treatments versus outcomes. And green is generally regarded as a good outcome, orange to red is a poor outcome. And you can see here, interestingly, the treatment modality which had the best measure of PDA closure was actually high-dose oral ibuprofen. So the double-dose oral ibuprofen. And it also, if you look down this column, had a better side effect profile as well, but didn't have as much effect on things like intraventricular hemorrhage as other medications might have. So it's an interesting way to look at the different treatment regimes and approaches to treatment, and I'd draw your attention to this, and there's a lot of other great information in this paper for understanding the different treatment modalities and their effect on different outcomes. So it brings me to supportive care as an alternative to PDA treatment. And supportive care usually consists of some sort of combination of these things: no non-steroidal treatment, optimising the positive pressure settings and the CPAP settings, careful fluid management, including fluid restriction, and judicious addition of diuretics at certain points. There are risks that have already been identified: caloric restriction and restricting the fluids too severely, which results in reduced cardiac output or systemic blood flow, and the risks of excessive use of diuretics. Despite this, though, and despite really any randomised trials, this has become common practice in many NICUs after failed as primary care, and also, of course, occurs as treatment for failed non-steroidal treatment with the duct still open despite having received non-steroidal treatment. So is supportive care safe? There's a concern about prolonged exposure to volume loads and the effect on pulmonary vasculature. Heart failure is not common, but it occasionally occurs. Is it effective? There's non-randomised studies show variable outcomes. More recently, some larger cohorts seem to be showing some improved outcomes, but there are some problems with their accounting for initial PDA deaths, for example, and deaths without ultrasounds knowing whether there was a PDA-related complication or not. So I'd just like to briefly look at two trials of supportive care. The first is in a Korean unit, a retrospective review of two approaches. 178 infants in a single centre study, small babies, 23 to 26 weeks, all diagnosed with a significant PDA. In the first period, this unit had a mandatory closure regime, so they used medical treatment aggressively, followed by ligation, and had significantly high ligation rates in these very small babies. Period 2, they completely changed their approach. No medical or surgical treatment, managed their babies with fluid, diuretics and PEEP, a typical supportive care regime. And if you look at what happened in their units, there was a significant reduction in or change in the PDA rates. So you can see here, this is period 1, and there's when they had mandatory closure protocol. You see, as expected, there's a very quick reduction in the number of babies with a PDA until it stabilises here, and most babies are closed, well, all babies were closed by the time they were discharged. And then if we look at the group of babies in the second cohort where they didn't have an aggressive closure regime, there were still, of course, closures, spontaneous closures. So this is really looking at the actual spontaneous closure rate of PDAs, because these babies didn't receive treatment. And so there was a slower reduction in the PDA patency rate, but eventually all babies closed. And in this cohort of 91 babies, every baby closed their PDA prior to discharge, which seems unlikely to me, because in our setting, even when we have fairly early aggressive treatment, we still have a number of babies who don't close their PDAs and who are discharged with an open PDA. I did have the opportunity to ask the primary author of this article what he thought was the contributor to why they had such good spontaneous closure rates, and he attributed this to their early fluid management protocols, which were actually quite conservative, with quite low mils per kilo rates for babies in the first few days of life, regardless of their PDA status. So I thought that was an interesting observation, and maybe something we need to go back and have a look at. The second, and the other thing I should say is there's no different in the morbidities or mortalities in those two different cohorts of babies in the Korean trial. Second trial is a retrospective cohort study in 2 European units. Again, a large trial, 297 infants. And in this unit, they managed to treat only 17 babies. The rest, 280 babies, were conservatively managed with supportive care. They all had routine ultrasounds to understand when their duct actually closed, and 85% of the babies had their duct closed, were closed spontaneously pre-discharge, which means that there were 50 infants who had an open PDA at discharge in this group of 297 babies. And again, there were no significant associations between neonatal morbidities and the persistence of the PDA, so there was no increase in adverse effects compared to their historical rates. Now, this group had enough babies to actually separate out the babies into different gestational age groups. Similar chart as before, with the PDA prevalence along this axis and the day of closure of PDA along this axis. And we can see that for babies who are greater than 30 weeks, the closure rates, spontaneous closure rates, quite high. Most babies are closed by 2 or 3 weeks. And then as we get progressively more immature, the closure rates are less and less, and the prevalence is longer and longer. And in fact, if you look at the smallest babies at less than 26 weeks, the median time to closure was actually 71 days. So babies less than 26 weeks were exposed to 10 weeks of systemic to pulmonary shunt. And that's, I suppose, one of the reasons why I think we need to study this a little bit more carefully, because that's a long time to be exposed to a potential significant shunt. And as we heard, 50 were open at discharge. So 26 infants died in this cohort. 16 of them had a cause of death potentially related to a PDA, IVH, NEC, pulmonary hemorrhage. So there were babies who died of ductal complications. Many of them died early. 10 infants died before 7 days, and all had a documented PDA. None received treatment. So there is a cost potentially for not treating the PDA in terms of early death and complications. But overall, there were no difference otherwise in morbidities of treated infants. They had 50 babies open at discharge, and you can see that here's the end part of their flowchart. 280 babies not treated. 43 in this had open PDA at discharge. There were 17 treated, 7 of them open PDA at discharge, so a total of 50 open. And then by 1 year of age, 30 have closed. So there were still 20 babies requiring follow-up from this cohort. So it's about 10% of their, or a little bit less, 8% of their babies still required follow-up because of an open PDA. And here is data from another trial looking at very low birth weight infants with PDA. 68 babies discharged with a PDA. Most of them closed, 52. Some of them were closed with a catheter. 7 still had a duct open even at 3 years of age. So there's a significant impost with these babies with ducts still open, because they require consideration about management of shunt. Some of these babies may still be on diuretics, delayed ligation, which may have its own complications. They may become eligible for device closure. And then there's a resource utilisation with cardiology follow-up appointments. And finally, the risk of PPHN or Eisenmenger syndrome, particularly if there's associated oxygen dependency and babies who are at risk of pulmonary hypertension. And the outcomes for these babies are not yet well documented, and I think need to be, because it is one of the complications of adopting a therapeutic nilhism approach and just using supportive treatment in your management of a PDA. I've mentioned the device closure a couple of times as a potential game changer in the setting of PDA management with high efficacies and low side effect rates. This is the Amplazza Piccolo occluder. You can see it's a very small device, now CE and FDA approved. Can be inserted by a transvenous approach, which is great for small babies so you don't get arterial complications, and can be used in small babies down to 700 grams, greater than 3 days of age. And as I mentioned, the initial trials have shown high success rates, low complication rates. This comes in from the venous side and is thread across into the ductus arteriosus. As you can see, the device is delivered, it's deployed, and then the catheter can be removed and you have complete occlusion of the ductus arteriosus. And so if we look at the evidence for this, there's been a recent review of this just published in Journal of Pediatrics in the last few months. And these are the trials of the device that have been done in babies less than 2.5 kilos. You can see that the success rates are high, number of successful implants versus attempted. The baby's weights on average are around about 1 to 1.5 kilos, and there's some major adverse effects, but not a lot. So again, some encouraging data. And if we look at the individual studies, this is one of the initial studies of transcatheter closure in extremely preterm babies. And we just look at the weights of babies who were treated with an occluder. You can see there are a significant number of babies now below 1,000 grams who have been successfully treated with a catheter device. So this has some potential advantages for us in that there's high success rate, high efficacy, and the side effect profile is certainly less than surgical ligation and probably less than medical treatment as well. So in the final few slides of my talk, just like to move to where we go in the future. So I've mentioned precision or personalised medicine, and prevention and treatment strategies that take individuals into account are becoming more important in all parts of medicine. So I think this is a challenge for us, is to try to personalise or precision our treatments by using some of the things I've discussed in this talk, patient characteristics, be it clinical, echocardiographic, biomarkers, understanding the timing of the treatment and how it relates to the physiology and the efficacy of drugs, spending more time understanding the dosing and individual pharmacokinetics. The PDA treatment is different to a lot of other treatments. It's not necessarily the peak that we're after, it's the area under the curve. And how to maximise the area under the curve to get ductal closure is something that we need to spend more time on. Use of predictive algorithms that might combine some of these things together may be useful, and understanding the predisposition of genetics and different responses, for example, to non-steroidals or to paracetamol. So this is the rise of personalised medicine, and this is ready, I think, to take over in time from the current therapeutic nihilism approach. So there are trials trying to look into some of these new ways of assessing the PDA, and these are four that I'm aware of: the Trio Carpi French trial, early ibuprofen treatment in selected babies with large PDA. The abstract of this was to be presented at the 2020 PAS, but of course with the cancellation, it was actually presented online. The Baby Oscar trial from the UK, Samir Gupta, selective early closure of PDA, still underway. The Benedictus trial from Germany, Willem de Bood, early treatment versus expected management in a specific group of selected babies. And finally, our smaller Australian trial with Kurt de Waal, early non-steroidal treatments versus supportive care, which I'll just show you a couple of quick slides on. So this is a trial is about to be published in the Journal of Pediatrics. 72 infants were enrolled. It was a pilot trial of babies who were selected by being less than 29 weeks, less than 72 hours, with the simplistic parameter of a PDA greater than 1.5 millimetres. And we randomised these babies to receive non-steroidal, either indomethacin or ibuprofen, or placebo. The important aspect of this trial, which we wanted to test, was we only wanted to give supportive care alone and not allow any open label non-steroidal. I've already mentioned that many of the PDA trials are contaminated by high open label non-steroidal rates. So we forbid open label from our study. So this is the way the trial ran. We had eligibility. We gave non-steroidals. We repeated the cardiac or placebo. Babies were eligible for a second course if the duct still hadn't closed after the first course of treatment medication. And then we observed the babies post-intervention and provided supportive care, increased CPAP, increased oxygen, diuretics, fluid restriction if needed. And there was the ability to triage for the baby to have a surgical ligation if certain criteria were met. Now, our outcomes were not what you might expect. And this is a pilot trial, and what we were interested in was two things. We were interested in the enrolment feasibility. Would parents and would clinicians accept a trial where we were abandoning the use of treatment and not allowing open label treatment? That's the way it was really looking, because we had a standard way of treating babies with non-steroidals. We were proposing that we would give a placebo instead, and on top of that, we wouldn't allow any open label treatment. Now, 54% of parents actually consented, so it was maybe a little bit lower than some of our trials, but it still was feasible to do a larger trial if 50 to 60% of parents would enrol. And the rate of open label treatment was 1 in each arm, so 3%. So we also showed that it was possible to do a trial with very low open label treatment rates. And we also found there was minimal clinician lack of equipoise. In other words, clinicians were all happy to enrol babies into this trial. We did look at other standard secondary outcomes. The PDA closure rate was higher in the non-steroidal group, as you might expect, and we found no other differences, but clearly very underpowered with only 72 patients to look at other clinical outcomes. This was a pilot trial in preparation for a larger trial with a similar protocol, proving that it was possible to do. So I'd just like to sum up in conclusion, some of the things we've looked at today. Earlier treatment points appear to give improved efficacy, and maybe we should be thinking about early treatment, but to do that we need to identify babies who really need the treatment. We know that prophylactic treatment results in 80 to 90% closure rates, and it's biased though by spontaneous closure rates and the open label treatment received in many trials. Later treatment closure rates are reduced down to only 50 to 60%. Differences are likely to be due to patient variability and the need to adjust dosage in older infants. So we need to know more about pharmacokinetics and pharmacodynamics of our PDA drugs. There's an increasing interest in conservative or supportive therapy alone of the PDA because of poor efficacy of the non-steroidals and the failure or the perceived failure to alter outcomes. And I think that sometimes it is very often a perceived failure because we don't look at the limitations of our meta-analysis. Conservative treatment is simple, but it's untested, and the effect of a prolonged untreated systemic to pulmonary shunt should be carefully considered. Cohort studies of conservative PDA management of selected patients have not shown harm, however, except for possibly some increased death rates in the first week of life. We've got this tension at the moment between groups who are interested in therapeutic nihilism versus groups such as ourselves who are trying to develop more sophisticated ways to personalise treatment into our babies. And the availability of non-invasive closure techniques may be a game changer with less risk, more efficacy, and the possibility of earlier treatment, even at the bedside in the NICU, is proposed for this new device. So I'd like to just leave you with one last thought, which is another way of approaching the PDA to get better efficacy. Maybe this is what we need to do, and this is already a medication available for treatment of fever and pain in older children and adults, and it may be that a double action for PDA treatment is the way we need to go. So with that, I'd like to show you a nice Sydney sunset, and I'm quite happy to answer any questions, or I'd be interested in your thoughts about some of these thoughts about the current perspective of the PDA in 2020.
Okay, so thank you. Thanks a lot, Professor Martin. It's really thought-provoking. So I received a few questions, and as you talk about therapeutic nihilism and personalized medicine, so there is one question. What do you do in your unit?
Well, I showed that we're more in the target. We're one step before the therapeutic nihilism. We're still at the targeted treatment. So we still believe that there are babies who benefit from early treatment. And we use a combination of clinical screening and ultrasound screening. So very premature babies under 25 weeks who are on a mechanical ventilator, who may have significant RDS, not received antenatal steroids. We do an ultrasound. We see that they have a large PDA, unconstricted, and particularly if they have early evidence of systemic to pulmonary steal, reverse flow in the descending aorta and diastole, that baby we would try and give treatment for in the first 6 to 12 hours, because we would like to try and prevent IVH and pulmonary hemorrhage, and we know that there is evidence that early treatment will do that. And we also feel the efficacy is better, and also interestingly, side effects are less in the first few days of life. So our aim is to identify a high-risk group of babies and give them treatment early. Then there's, after that, we're not so fussed. Older babies, 26, 27 weeks on CPAP, we tend to just monitor and see that the duct's starting to constrict, and we don't treat those babies routinely, only if they're special circumstances.
And you use ibuprofen or paracetamol? Or
Ibuprofen in fact, I use Indomethacin. That's still available for us. So I use Indomethacin in the first place for treatment. In the first week of life, my preference is Indomethacin because the data supports IVH and pulmonary hemorrhage prevention. After the first week of life, I use ibuprofen. And paracetamol is our second-line drug if non-steroidals fail.
Okay, there is there are two questions actually related to each other. Is what is the role of pro-BNP in monitoring hemodynamic caused by the PDA?
So I think pro-BNP does have some utility, but it's problematic in some ways. First problem is many of the studies have shown a huge variability in the normals of pro-BNP, so it's a bit hard to know what the normal is or what abnormal is. The second thing is that I think pro-BNP is often a later effect from the PDA. It's not there at the beginning, but when we start to get dilatation of the heart, then we start to get changes in pro-BNP. So I think it's useful as a monitoring to see that it's getting better as you're treating the PDA, but it's more difficult to use it as a decision point tool.
One question, Martin, sorry. There was a question is from one of the viewers that can we classify a PDA, whether it is significant or not, based on diameter and LA ratio, if otherwise child is asymptomatic?
Yes, so there's a couple of things there. It's an asymptomatic child, but has a large, can we then use the ductal size or diameter plus or minus the LA aortic ratio to assess hemodynamic significance? So I think it's getting more complicated. When the first thing that we were interested in was ductal diameter, and we've used that for many years, but I agree with others who have criticized that to say that's too simplistic. So I think what we now are interested in is we need to have increased diameter, but also evidence of a left to right shunt of significant volume. And we assess that by multiple parameters, looking at the systemic side and the pulmonary side. So typically I would use 4 things: PDA diameter, the flow pattern in the duct, because if there's evidence of ductal constriction, there will be a flow pattern which is different to one with a wide open PDA. I look at the flow of blood in the diastole in the descending aorta for evidence of systemic steal, and I look at the left pulmonary artery diastolic velocity. And if all 4 of those things are positive on my parameters, that baby, I think, has got a hemodynamically significant PDA, and I would treat. But I would also look at the clinical context. So I might still give a baby the benefit of the doubt if it was 28 weeks and had all those things. Whilst if it was 23 or 24 weeks, I would definitely treat. The LA aortic ratio is a little bit problematic because I feel it's not very useful in the first few days because it takes some time for the heart to dilate with a big shunt. And the second problem is that the PFO acts as a decompression device. So babies who have a very big or a large PFO, even if they have a large duct, the left atrium just decompresses across the PFO and we don't get an increased LA aortic ratio. So there are some limitations of the LA aortic ratio in some babies.
Okay, so there's another question if I have time, Rajesh. There are actually 2 questions. Is there any time, Rajesh, we can ask?
We have 2-3 minutes.
2-3 minutes, okay. So there is one question about that: can treating the PDA in extreme premature babies worsen the PPH? And I think he or she is talking about the prophylactic treatment.
Yes. Yes, and it's a good question because a number of the prophylactic PDA, well, the ibuprofen trial anyway, was stopped. The very early prophylactic ibuprofen trial was stopped because of concerns of pulmonary hypertension. So we always do an ultrasound because we can do them ourselves before we treat a baby. And if a baby has a significant right to left component of their ductal shunt, then we will delay treatment and reassess the baby at a later point. So yes, it is possible to close a PDA in a baby who has raised pulmonary pressures with significant right to left shunt, and that can cause an acute decompensation of a baby from a pulmonary point of view. So we would recommend always doing an ultrasound to screen for significant right to left shunt prior to treatment. Even in the so-called prophylactic approach, what we're really doing is we're actually doing early targeted, and that means doing an ultrasound as well, and then you don't have that problem.
Okay. So there's one interesting question, last question, because of the time. I have a few more, but I think you cover everything. So this is the question because I think the participant is more excited about your personalized medicine way of management. So they said if there is any special markers, you know, you already answered about the BNP, but is there any other biomarkers you are using it?
Not that I'm using, but there are other people looking at many different things, and I think it's going to be, including the genetics. Yeah, the genetics of the PDA. It's very interesting. There are some babies who may respond better to non-steroidals, some babies who may respond better to paracetamol, some babies who will never respond. So I think this is really what my idea is, and my feeling is that we need to spend more time looking at these parameters. We should throw the net wide, look at many different things, and then we should then try and rationalize these into what groups of babies, what risk factors babies have, and then treat babies even with different medications at different time points. So that's what personalized medicine is, and we're moving towards that in many other parameters. I mean, in hypotension management and choice of inotrope, we need to be more personalized and not algorithmic. We need to understand the physiology, and I think so. I think there are many potential markers, and I mean, I wrote an article with Petra Lemmers a couple of years ago, and we looked at non-ultrasound ways of assessing the PDA, and there were about 50 of them, including platelet count, for example, has some relationship. There are many interesting things that can be used to assess the PDA even beyond ultrasound, and I think we need to start trying to understand them and bringing them together, and then saying this particular baby would respond best to this baby would respond best to another form of treatment. So.
One question before we wrap up. Sorry, interesting one. Nowadays, because of a lot of people are going towards paracetamol. So question is, if a baby has been given a course of paracetamol and it fails to close the PDA, can you switch over to ibuprofen? And the second part is, can the two be given together also?
Well, that was the aim of my last slide, of course, because that was exactly what that was. There is a preparation that we give our children already in Australia, which has got a combination of ibuprofen and paracetamol. And so I was initially concerned about giving those two drugs together. Has anybody on the panel given those two drugs together at the same time, ibuprofen and paracetamol?
You know, only for fever, alternate.
Alternate, but not together.
No, not together.
Yes, I was worried if we did that, I might do something really bad to the baby to give them, you know, the two peroxygenase and co-oxygenase inhibitor both together. But then I looked, and one of my daughters showed me this medicine, and she said, "I'm taking this for my fever." I said, "Oh my goodness, they're both already combined together, so it can't be that bad. So maybe it's okay to give to a neonate." So I think yes, it's okay if paracetamol fails to go straight to ibuprofen. And the question is, should we be using both together? And would that actually increase our efficacy rates? And I've seen a couple of case reports of dual treatment, but nobody has done a clinical trial on that. So there's an idea for you.
But my problem is that if the efficacy of both medicines are the same, then how one can better than it's just a trial and error. You know, the new Hippocratic Oath you said.
Different mechanism. So it's
different mechanism. Yeah, exactly.
One works at one end of the one's co-oxygenase, one's peroxidase. So I think it's having an effect at 2 different points in the prostaglandin pathway.
So I think it goes towards your point of genetic and the genetics biomarkers. Exactly. So
absolutely. So it's important to understand that a little bit more, because I think going back and meta-analyzing 20-year-old trials and then trying to say that the treatments don't work, I can't see the point in doing that anymore. I mean, it's served its purpose. We need to move on now from that and say, okay, we all know that there are a small group of babies who benefit from getting treatment or prophylaxis from IVH or pulmonary hemorrhage. Let's identify those babies. And there's also definitely a group of babies who go on in the nursery and just get sicker and sicker. They go into heart failure, and eventually they get ligated at 5 weeks or 6 weeks. Can we identify that baby earlier and give them catheter treatment, for example? And I think that catheter occlusion device will make a big difference in the future, because that's potentially able to be done at the bedside with an image intensifier. And it's very efficacious and seems to have very little risk. So it's being decided at the moment, the role of the occluder. It's not something that's everybody's using by any means, and it still needs some research, but I think it's an exciting new development that will make a difference to our management in the next few years.
Thank you. I think we have to wrap up now. I'm sure we can continue discussion throughout the night as well. There's so much of interest, but we need to get in Dr. Monica Kaushal. I think she does not need any introduction in UAE and across the world as well. So Monica, can you please take over and introduce our next speakers and moderators? Thank you, Dr. Junaid.
Thank you. I would like to thank Dr. Martin Kluckow. Thank you very much for his beautiful lecture and the discussion, and very thought-provoking. So thank you, all the team. Over to Monica.